Brilliant. Thanks, everyone. So, a huge welcome from me to your celebration day. Gosh, it just feels like 2 minutes since we were starting off this programme, and here we are 7 months later. And you've been on this journey that I promised you all those months ago of various different learning opportunities. And I guess what I did say to you at that time was make the most of it, throw yourself into it. And what I've heard from feedback from all of your facilitators is that that is exactly what you have done. So you have been a group collectively that have stood out. People have constantly come back to me and said, my goodness, that mental health nursing group are just fantastic. Positivity, a real drive to want to influence change, and particularly for the workforce, and also raising attention to the mental health nursing workforce, and also to be able to advocate and champion for the needs of mental health service users. So it's been an absolute pleasure to have you as part of the Florence Nightingale Foundation family, and long may it continue as you become our alumni. So today's session is all about celebrating you. It's about celebrating your learning, what you've achieved, and also starting to think about some plans for how you will use this opportunity as a platform for the next stages of your career. And that's really the most important message that you should take from today, is that this is the motivator, this is the starting point of this experience, but it will last for the rest of your career while ever you engage with us as the foundation, and we can continue to support you in this way. So we've got some really great people here to speak to you, and I'll introduce them all as the morning progresses properly. But just before we get going, so you know who's here in the audience, Rita, would you like to say just a quick hello, introduce yourself?
Good morning, everybody. I can't see everyone. I'm so upset we're not in the same room with a glass of champagne. A bit early for a glass of champagne, but I can't see all of you on my screen either. But really good morning. Gemma, do you want me to say stuff now, or are you going to ask me to do that in a minute?
Just in a minute, just some intros first of all, Greta.
Okay. Oh, shush.
That's me. So Greta's our chief exec, and we've got here Becky Burgess-Dawson.
Good morning, Gemma. Thank you so much for inviting me. My name's Becky, and I'm the clinical lead for the mental health programme at Health Education England, and I'm a mental health nurse by trade.
Brilliant. Thanks, Becky. And also Maria Nelligan.
Good morning. Hello, my name is Maria Nelligan. I'm Chief Nurse at Lancashire and South Cumbria Trust, and I'm delighted to be here. And thank you for inviting me. So I'm really looking forward to hearing the presentations this morning.
Fabulous. Well, you're really welcome, Maria. Thank you for coming. And we've also got Susanna here, from who you'll remember from your QI session. So Susanna, did you want to say hello?
Quick hello, and I'm really looking forward to hearing your presentations, and I know that Claire Henry really wishes that she was here as well, so but I can't wait to hear how you got on with your quality improvement projects.
Thanks, Susanna. Okay, so we'll start off with our programme, which is a welcome and some messages from Greta, our CEO. So as Greta said, she heads up our foundation. She's a nurse by background, over 39 years in the profession, and recently awarded her CBE for her contribution to nursing and midwifery. So Greta's joining us here today to give us a message to you, some thoughts about how you can use this opportunity moving forward.
Thanks, Gemma. Oh, so lovely to be here. And as I said in my introduction, so sorry that we're not in a lovely high class or a lovely venue in London, and we would normally be doing that had it not been for COVID, that damn thing. So we are where we are, and I just really want to say thank you so much for keeping on track, for going with the flow, because it's not been easy over this year. And well done for turning up at all the sessions, because you could have easily said, actually, my clinical area is too busy. I'm not going to pay importance to this. But it is really important. It's been more important than ever to make sure that you pay attention to your professional development. So really well done. Now, I actually don't know any of you, which is interesting. And that's a sign of the times, I think, because I think up until now, all the groups that I've welcomed on the celebration day, I've had some input in the selection and then some input into the programme. But I think you're my first programme that I don't know any of you. And I was sitting here listening to Gemma talking to you by some of your first names, and I thought, oh, I really miss that. But anyway, there will be a point in time that we will meet together. And my point about just saying hi to you today is I really hope that you've enjoyed this journey. Gemma said it's a journey that you need to immerse yourselves into, and I understand that you definitely have. It's probably been a fast ride for some of you, but I think that for those of you who have really, really enjoyed it, I would imagine that you've taken it by the, well, I better not say that word. You've really experienced what it is to be on a leadership program, and the reason that you were chosen is because you're already superstars, but we want you to be even better. And I guess by applying and being nominated by your chief nurses, you have been recognised as being super nurses. So that's a great starting point, and we really want to understand what happens to you through the rest of your career. Adam, I know, is on the call, and he'll probably talk to you at the end about being an alumni. But if you could give your consent to us contacting you on a yearly basis, it gives us some credibility about what's happened. Of course, we would always say it's to do to the Florence Nightingale Foundation programme, but actually we've given you the grounding now that we hope that it's given you the confidence and the courage to be even more courageous, to take the next step in your leadership journey. So we would love to follow you up if that's okay. So I'm hoping most of you would agree to doing that. So yes, fabulous to have you. At the end of today, you'll be a Florence Nightingale nurse, and we will award you your certificates. And I'm not sure how the badges get to you, but they get to you somehow. I'm sure Miriam knows how to do that. But really, really amazing. Thank you so much for putting all your energy into this. It's been a tricky year, and I'm sure that your patients, the people that you look after, have really suffered in this time. But thanks to you, that you've been able to provide an extra special comfort for them and wraparound service for them. And because we know what's happening to nurses and midwives during COVID, I can only imagine that your skills, your attributes, your knowledge and experience is really going to help your colleagues over the next few years, as I'm sure when COVID finishes, that this is not going to finish. And your support as mental health nurses will be even more important than it is now. So a big thank you from me. Fabulous. I've got a couple of things that have cropped up since yesterday, as they do when you're a chief exec, but I promise I'll be in the background. I'll turn off my mic and I'll turn off my screen. But I really want to understand. I'm not a mental health nurse. I was a midwife and an adult nurse. But I want to understand what it is that you've done over the last 7 months. So I'm really interested in your improvement projects. So if that's okay with you, I'll turn off everything, but I will be here listening. And if I'm still here, I've not been drawn into something else, then I will say a goodbye at the end of the session. Is that okay, Gemma?
Yeah, lovely. Thank you, Greta. Take care. Thank you. And I'd also like to introduce you properly now to Becky. So Becky, I've had the pleasure of meeting Becky since I've been in post here at the foundation, and Becky and I find ourselves on similar meetings and steering groups, and it's always a pleasure and a relief when I see Becky there on those meetings and those calls. And the reason for that is because Becky, in a conversations and meetings that often can be quite abstract, or people thinking about maybe future visions and plans, what I always value about Becky is that she grounds it every single time. Her contribution is about reality, and it feels so important that those people that are making those decisions really have that clarity that is offered by Becky's perspective. And I don't think that, I don't know many other people in the position that Becky's at as a national clinical lead for mental health at Health Education England that can manage that very fine balance by having that grounded and clear and real perspective and being able to translate that to these very influential policymakers, funders, those kinds of things. So I'm absolutely thrilled that Becky's been able to join us this morning to talk to you guys, and also to say a huge thank you to Becky on behalf of the foundation to Health Education England, because they have funded and sponsored this programme. So we're all here today because of the mental health programme at Health Education England. So over to you, Becky.
Oh, Gemma, I couldn't blush anymore. It's anemic pallor. Thank you. Thank you to you, all your colleagues there at the Florence Nightingale Foundation, and thank you to Professor. Hello, everybody. My name's Becky and I am a mental health nurse. It's an honour and a pleasure to be here, to be invited to say a few words to you, but it's also on behalf of Health Education England. We are so proud to be funding this leadership development of mental health nurses in this way. And thank you to all of you for being on this journey with us. I must tell you a story. Some years ago, I was invited to Westminster Abbey by a colleague for a special service. And I found out that it was the Florence Nightingale Foundation. And I'll admit to you now, in the spirit of honesty and transparency, and especially sitting here now, more than mild embarrassment, I Googled the Florence Nightingale Foundation. And I read a couple of things. It was created in 1929. And it was advancing the study of nursing and midwifery practice as its primary aim, promoting excellence in practice to benefit patients, and does this by creating a programme where nurses and midwives are empowered to use their professional voice effectively. That's exactly what it said on the tin. And I was very, very impressed with all of that. You're here to join an incredible alumni. These are laudable aims, and I think they follow them through magnificently. I digress though, back to my visit to London, my trip down London town and my first visit to Westminster Abbey. So I'm sat in the choir stalls, huge place, and I'm seeing nurses and midwives. I've only seen them on podia at international conferences before now. These are clinicians whose names I've cited in my essays, and there's beautiful organ music going on. And then right then, down the centre of the aisle, through the main doors, a procession of nurses through the ages. There's beautiful uniforms showing how they've changed over the years, flowing Victorian capes right through to modern scrub uniforms, and then right at the back, the most recent addition, a group of nursing associates. And I was almost tearful and in awe of this spectacle, this beauty and this glory, this deliberate and respectful procession throughout history of all my profession, nurses who made this a profession in the first place. And then I had another thought. I thought, where are all the RMNs? Now, you must forgive me, in my generation, we'll always be RMNs. How are they going to depict the RMNs? I almost started giggling in church, it's a terrible thing. I thought, is somebody going to wander in late because they were caught up in a conversation with somebody, getting to know them and their story? Are they just going to wander up the aisle? What's their uniform? Are they going to wander up with half a drunk cold mug of tea and a well-chewed biro? And then I scolded myself. Because we always do this. We always do this, us mental health nurses. We always think we're nurses, but we're not. We demand that we're the same, but we're very different. It's been the same throughout my career. There are so many options and opportunities for us, but how to make the best of us? What way? Shall we be a clinical specialist, a researcher, a lecturer, an academic, or just the best of a job in RMN? Because in the midst of a pandemic, we have a bit of an RMN crisis of confidence. First of all, the beginning of the nurse and midwifery call to arms, the beginning of the pandemic. And you think, what use are us? What use are a nurse that can't operate a ventilator? And then more recently, some blessed relief, the licensing of a vaccine with RMNs, and we are brilliant at deltoid injections. And now, slowly, we're coming to an understanding, you and us, this is the beginning of our time. We now have a nation desperate for support. After all this trauma, it's just starting to come forward. People are just starting to come forward for that help, that care, that compassion that you and I and our teams will bring. We're the profession that can meet all their needs. Their biomedical, psychosocial needs are all encapsulated in our skill set. We're part of people's communities and we care. And there's going to be lots more of us, lots more. I'm reading in our press at HE that almost 50,000 new people have applied through UCAS to begin a programme of study that will lead them to be an NMC registrant. That's a 34% increase. And my mental health workforce analysts tell me today that lots of those applicants are looking forward to not having to wear a uniform. So we have the need and we have the next generation. And so we need you. I need you. I need your knowledge, your skills, your abilities, and that personal journey that you've just all been on as part of this programme. Because I know you've got the strength and the stamina because you just did a leadership programme in a pandemic. I know that you've got the people skills to engage with people and help them realise their potential. And I also reckon, as a person who's finished a few learning programmes in my time, I can empathise that you're a mental health nurse who's just found out there's a whole lot that you don't know yet. But overall, we think we know more than we sometimes give ourselves credit for. So I guess I was asked to come and help start your day because of this, because of who I am. And I guessed that because I've got a quarter of a century of mental health nursing, that I might have something in common with you. But I actually came here this morning with a bit of an ulterior motive. I came here because I need you. I need you to help leaders. I need you to lead from every single chair, from board to ward, in every team, in every service, in every school, in every university, wherever you ply your trade, this special service, just like every other nurse and midwife, but we're so very, very different. You make mental health nurses and their contribution to healing communities clear and present, as much a part of that procession up the aisle at Westminster Abbey in every service that's yet to come as soon as we're able. You deserve your place there. It's a pleasure to have you in my RMN family. And it's an honour to welcome you as an alumni of the Florence Nightingale Foundation. Congratulations. It's lovely to have you. Please enjoy your day, you deserve it. And thank you for listening to me and indulging me for a minute. Gemma, thank you.
Thank you so much. It's got to be a round of applause, that, hasn't it? Wow. Thank you so much, Becky. My goodness, honestly, my face is aching. The grin on my face and my heart. Oh my goodness. That was fabulous.
Yeah.
Sorry, say again, Lauren.
How about crying in room with how inspirational that talk was? I feel like, what? I feel like I'm buzzed. I'm thinking, gosh, we just need to, I don't know. Thank you. I don't know if anybody else is feeling the same thing. Thank you for that. I just feel like my Thursday's just got
I'll do me.
Brilliant. Thank you so much, Becky. And Becky, you're staying on the call for the rest of it to hear the presentations. Brilliant. And one of the things that I said to you at the beginning of the programme is being part of the F&F family opens doors. It enables you to make connections, and Becky is one of those connections for you. So she's met you all now. She's given you a call to action. She wants to hear from you. She needs your intelligence. She needs your leadership. She needs your contribution. So please do let us help you to network with people like Becky in those roles at HE and other national posts. Thank you so much, Becky. So we'll start off now listening to our presentations. So the way that these presentations are selected is that two members of the team, so Claire Henry, who's our QI expert, works with Susanna, and a member of the F&F team, look at all of the abstracts independently and they score them. And we select 10. We select 10 to present, and 5 to present and 5 that are highly commended. And the people that we're going to hear from today are the people that were selected as the top scorers. They were the ones that are here to present. So congratulations to all of you that were selected both to present and highly commended. What the message is, though, that the standard was outstanding, and the level of innovation that has happened in such a challenging period of time blew everyone's minds. So congratulations to you all for what you achieved through the programme. And we could have actually listened to every single person. And if we were all in a room together, we perhaps could have found a way to do that. But this is our compromise. We'll hear from our 5 presenters now. Now we're doing fine for time, but I'm going to need to ask our presenters to do me a favour. so that we stay on track. We've got about 10 minutes each for each person to present. So if you could bear that in mind, 10 minutes is a good time. It will enable us to do a few questions and have a little bit of flexibility afterwards. So a call to help me out with chairing here from our presenters. It's another leadership challenge to stick to our 10-minute time scale. So first up, we've got Anastasia, and Anastasia is a CAMHS specialist mental health practitioner. And whenever Anastasia is ready, we've got your slides and we can control those for you. So you tell us when you want to move along.
Hi everyone, I hope you're having a lovely day. So my service quality improvement project was on improving transitions from CAMHS to adult mental health services or local mental health teams. If you're all right to switch the slide. So transition is described as a purposeful, planned movement of young adults with chronic conditions from child-centered to adult-orientated healthcare systems. It's estimated that around 25,000 young people transition from child and adolescent mental health services or CAMHS to adult mental health services or AMS in the UK each year. So research has identified that current barriers to effective transition are cultural differences between CAMHS and AMS, and that there is a need for increased cooperation between services. So the project that I did sought to promote commencement of tiny transitions, which is about the 6-month marks when a young person's 17 and a half, to adult community or local mental health services to promote improvements in liaison and communication. So I was based in Nottingham at the time, so this is when the project was undertaken. If you're all right to switch to the next slide. So the first bit that we did in terms of methodology was to gain an understanding of the perspectives of CAMHS clinicians. I developed a mixed method survey posing 10 questions to support the gathering of quantitative and qualitative data. So the survey questions provided were 5 options, so strongly agree, neither agree nor disagree, and strongly disagree. And then there were some options to add additional comments about clinicians' thoughts and feelings. So I put an email out to my team, which was the CAMHS South team, and to our CAMHS crisis colleagues to get a bit of an understanding, and there are 23 respondents to the survey. So the questions focused, so the questions focused on the confidence of clinicians in referring to young people, if they were successful in doing it about the 6-month mark, support's available in the team currently to have discussions and their perspectives on the interactions. Right, and so here are 2 of the graphs. They're just I did it on SurveyMonkey, so this is what I came back with, which is quite helpful, to be fair. I didn't have to compile the data myself. So they kind of looked at 2 of the questions, and as you can see, confidence levels varied, which is really interesting. So you can see from there was about a 50-50 split in terms of agree or disagree and confidence, and the feeling that there was a shared understanding around what our roles were in CAMHS and what the roles were in adult services, as CPNs, as community nurses, what we needed to do. So the results, as I said, kind of looked at varying levels of confidence, that we didn't feel there was there was a shared understanding, and these concerns mirrored current evidence and research, which looked at the difference in care philosophy, and also I guess the difference that CAMHS and adult services have in terms of what they need to meet, the age ranges that you need to work with. So that influenced, this is how it influences transitions between services and the experience of clinicians, young people and their families. The final question that was posed in the survey, which was my idea, was looking at if we held transition meetings, would this be helpful? Would this be something colleagues would come to and be interested in? And 100% respondents confirmed this is something of interest. So from that point, we kind of went with the approach, which was to get these meetings started. So I liaised with the clinical nurse specialists in my team to kind of develop these meetings. So it was agreed that their involvement would be they would lead the meetings. I also attended on them, and that we'd look at a maximum of 4 clinicians who could attend to discuss cases of young people aged 17 to 18 years old throughout that transition period. The rationale for clinicians attending was so we could have 15-minute slots, so we could have a proper chance to talk about what the concerns were, why we felt things needed to transition, what we could do. So meetings were held virtually, as we are today, due to the impacts of COVID-19, and the format of meetings changed to promote professional attendance. So initially I came up with a form, and I thought a form would be a good way, but actually it was just quite time consuming. So we moved it to an email just in going to Outlook calendars, where it was like you can sign up if you want to, or you can ignore it and come to the next one. We also invited adult community team leads to kind of get an understanding of, you know, what the wait times were, what services are there. Like in CAMHS we offer family therapy, and adult services that isn't available. So what things were available to our young people to set realistic expectations to them and their families as to what the difference in service provision was going to be. And the transitional meetings received positive verbal feedback, which supported that the meetings needed to continue, they needed to develop. And there was a sense that it offered security, where we could discuss cases with an element of risk and containing families. So my leadership learning. So for undertaking the project, I felt my leadership skills developed regarding my communication skills. I developed the confidence in terms of contacting professionals on varying platforms such as virtual and email, with the challenge of not being able to go up to someone's office or, you know, pick up the phone because we don't know if everybody's going to have access to their phone to have conversations. I felt my management skills developed in terms of, you know, delegation of tasks, interlinking both professionals, looking at, you know, working with those that are more senior to myself. I've learned to positively respond to constructive feedback, you know, comments on the project, what could be done differently, to kind of take that forward. And I felt my conflict management skills developed regarding responding to professionals with different viewpoints and promoting a shared understanding for active listening and a focus on collaborative working, which is always the goal in any form of transition. And that's it. That's my present. Oh, yeah, that's my presentation. That's just the bibliography.
So much, Anastasia. You got us off to a brilliant start. And now I know there'll be some questions and comments, but while everyone's getting warmed up, I'm going to ask Maria if she's got any reflections or thoughts on what she just heard there from you.
And just a great piece of work, Anastasia. And it did remind me of a piece of work I did maybe close on 30 years ago with people with learning disability transitioning between school and into the adult world. And I was just reflecting and wondering, have you thought about when you move on in your career journey, how you can make this really, really good initiative stick and become embedded within the area that you work in?
I think the challenge is I actually left the area that I work in. So I moved from Nottingham to Edinburgh recently. So I'm kind of looking at how I can do it in my new team, because I've moved from CAMHS in Nottingham to CAMHS in Edinburgh and NHS Lothian. But I guess the hope is to continue to look at points of access. I guess it will be seeing what the differences are from what I faced. I guess I still have contact with my colleagues back in Nottingham, so I can always see what they are doing. But I think transition remains a massive issue. And I guess the difficulty is in terms of framework, that it's not a requirement in the sense of it's not got the same structure we would hope for. So I guess it would be continuing to look at what's happening with policy, if there are changes to policy, how that can influence us. I think the best thing is just to have a point of contact. I think the thing that, as I was leaving the team, I understood the personality disorder service, which I guess a number of our referrals were going to for young people with emerging personality disorder, was going to set up a point of contact for transition. So I think there were, you know, real successful things that were going on. And I guess it's just seeing what's happening up here. Now I've moved and what I can do.
Fantastic. I'm sure you'll be wonderful.
Thank you, Maria. Thank you, Anastasia. Any thoughts, Susanna, on how that PDSA cycle might help Anastasia to think about how she might transition what she's learned into a new setting?
Yes, Anastasia, brilliant project, well done. And I love the fact you just went and found SurveyMonkey and found it really helpful. So that's fabulous. I think when you have some of these ideas and when you're thinking is trying to progress to doing those small tests of change quite quickly, and making sure when you're working with another team that you're really engaged in what their perspective is and learning how to walk in their shoes, because I'm sure they would love to be doing all the things that you really want to do, but they've probably got their own pressures. So just really understanding that side of things, and PDSAs, if you can get, for example, the adult team to do tests for you, then you're a game changer with these situations, because they'll own some of the ideas that you're coming up with. So if that makes sense. But it's a brilliant project. I loved that you created such a clear background, and you grew the confidence in technology and use of all those shortcuts that technology offer, really understanding how people communicate. So it's such brilliant, yeah, well done. Really good to hear.
Thanks, Susanna. Thank you.
Yeah.
Any comments from others in the audience?
Can I just say that, I mean, I've been in Anastasia's group since the beginning, and even just seeing her just present this, her like confidence and the way that she portrays her ideas has just grown like immensely. Like, I was so proud when I saw your name. I was like, oh my God, Anastasia, yes! You know, how much you've grown it in the last sort of probably it's been 7 months, but just thank you. And I was always supportive of your idea. I thought it was amazing, and obviously it's worked. So I'm hoping Edinburgh, they're lucky to have you, put it this way. So well done.
So much, Lauren.
Oh, thank you, Lauren. And you know, if RADA were here, Anastasia, they would agree with what Lauren said. It was so clearly presented. We heard every single key point that you wanted to make there, and I've got take-home messages that will sit, and I'll reflect upon those things. So as a presenter, you absolutely nailed that. So well done. Thank you so much. Okay, let's move on to our next presenter. So it's Henry next. Henry's a staff nurse and is going to talk to us about the management of patient property in the ward environment. So whenever you're ready, Henry, over to you. Oh, you're on mute, Henry.
Hi, everyone. Good morning. Can you hear me?
Yes.
Oh, thanks. My project was just about managing patients' property in an acute ward setting. It came up as, what I liked most about the whole thing was that we were given the choice to look at a project that means a lot to us and work on it. And so I decided to do this. It was spurred mainly by the fact that there are lots of cases of misplacements and loss of properties on the part of staff, patients' properties by staff. And obviously this was leading to a lot of an increase in agitation on the ward, violence and aggression, and also the fact that as much as sometimes the ward would refund the patients on this, there were lots of properties that had not just monetary values, but emotional values and attachments to them. So I think it's important for me to point out, I left the story there. We don't need to go through all the story, but I'll cut it short. A patient I'll choose to refer to as Mark. Mark came to us quite unwell during the first pandemic, during the first wave of the pandemic, and he was quite unwell. So one of the presentations of his anxiety was he usually was incontinent. So on one occasion, he again, I point back, Mark had gone to a very prestigious university years back and kept his sweatshirt, which he wore most of the time on the ward. Actually, most of the time wouldn't want to take it off. So on this occasion, when it was messed, patient staff helped him obviously attend to his personal hygiene and took the top away. So after the whole situation, can we move to the next slide, please? After the whole situation, it so happened that nobody knew where this sweatshirt was. So the reason I captured this slide, what would you do, was there was a situation where the sweatshirt was being looked for, and we had a handover where the day team and the night team met. So it was where there was a mix of well-experienced, old staff, new staff, everyone. And it dawned on me right there that there was so much subjectivity on how to deal with situations like this. The truth was, the staff that attended to Mark had actually disposed of the sweatshirt. So, and whilst a lot of people thought, oh, you wash it, some people thought, no, we always pack it and throw it away, it's been messed up, infection control. So whilst I watched this and looked at this, it was clear to me that there was no clear process. There was loads of subjectivity. So I thought this would be a good project to do. So basically what I did was I looked at the information on the number. I tried to create get a picture of how big this problem was. Despite what I'd seen, I wanted to see how big it was. So by looking at what we had on the ward, I realized that there were loads of patients' property lying everywhere. There were loads of things. I mean, some patients who had been discharged from what I was told by my teammates who've been there for longer than I was said some of the patients, when we were looking for things, some of them had gone 5 years ago, but we still had some properties that belonged to them. So we started working on trying to look at some numbers, trying to look at how big the problem was. So we looked at things such as how many properties that were there that belonged to patients who were not on the ward, who had been discharged or transferred, how many things, how many reports of missing properties, and how many properties or items we found that had no clear identification. So we started looking at this as a benchmark or a baseline to kind of ascertaining what the problem was. So kind of putting and saying, if we could reduce this by at least, if we get it down to at least 30% by the deadline of the project, that will be an achievement. So what we did was we decided to look at situations whereby where would these problems come from? It will come mainly from coming into the ward admissions or transfers. And obviously COVID was happening. So we tried to see, okay, fine, we're getting loads of patients coming. We said, okay, fine, let's design, apart from what we had on an admission checklist, which was little or nothing, I went there and designed a little template as to what could happen. So I assigned a particular person to follow up property management from beginning. So as in why the search was done, the tagging, the labeling, the identification, the storage. Then documentation of this was done, apart from in the book, we did that on Rio. And so just to kind of ensure that, we could trace these properties wherever they were. And we also looked at a situation whereby, deciding which properties were to go where was quite subjective. Like some people would do a kind of a blanket. If you came in and you had, let's say, phone chargers or cables, they will all be taken away from you. So it wasn't based on risk assessments. So we thought, okay, why keep everything while some patients could keep theirs? And by keeping them, the chances of them getting lost. So we actually based this on risk assessments, and people who didn't have those ligature risk, risk would be handed over their properties. So we looked at these things and then kind of tried out, practicing what was on our templates. But there was a difficulty there because obviously having to work with the challenges we had in terms of staff turnover, in terms of the shortage staffing issues, all kinds of staffing issues. It was quite difficult to get this to every member of the team. So what we decided was to work with, to kind of recruit, whoever we could, and to work with kind of more efficiently than, trying to get everybody there, especially since we had limited time to achieve this aim. So we looked at that, and then in the process of looking at this, we realized a very important factor. We actually couldn't find a trust policy on the management of patients' properties. So there was actually not much. I mean, that explained the subjectivity because people were, doing whatever they thought was right. So, however, we continued with the process and tried to solicit for more team members to join, tried to get a clear definition of management of properties. We kind of came to a point that management will be from the point of entrance to actually retrieving at point of discharge or transfer. And, with that checklist and with the things we put in place, we managed to actually see some improvements over the weeks. And we continued by this, trying to spread the word. And we noticed as well, again, another downside, because of the limited time, we couldn't actually pinpoint exactly in specific numbers, but we saw a big slump in the reduction in violence aggression as related to loss of property or property issues. And so that's basically what we did. However, if you see on my diagram, my chart, towards the last week, which kind of coincided with December, my ward was converted to a COVID ward. So all hell broke loose. As I'll say, COVID happened and there was a massive slump. So the leadership learning from there is basically the whole, the actual ability to put into practice what I'd learned in terms of capacity building, in terms of negotiation, in terms of trying to work with people around. I would say prior to the training, I was the kind of person who probably had wanted to do much more on my own, and would probably look at if the interest, if I don't see a clear interest, I'll probably be like, that's a waste of time, especially since there was a short time. However, I kind of learned, I kind of harnessed the skills and resources through negotiations, deliberations and understanding, mainly communication. And also kind of it touched on the negative culture in terms of this, which stems from what I found that to be not just people being bad and negative, but training issues and, people having to sustain negative practice. So we were kind of able to build the required network to achieve, or kind of to get an inroad to a change of culture. And then also another thing from there is a big situation could come in at the middle or any part of a project, in this case COVID, so a leader should be able to know how to navigate such terrains. And I'll add one thing quickly, that since this project, my trust has shown massive interest in this project, very massive interest. We're looking at policy development in this field. And I just met with the deputy director of QI, and they're looking at this project in terms of, taking it trust-wide. I think I'll stop there. I have the tendency to talk a bit too much.
Well done, Henry. Brilliant. Fantastic. I've got a conclusion to the story there. And I wonder if Mark knows that his experience had such a massive impact potentially on the whole organisation and what you learned from it.
Unfortunately, I haven't been in touch with Mark myself, but the Deputy Director of Nursing actually posed the same question, and just watch this space.
Yeah, absolutely. Do you know, actually, Henry, this week I've been doing interviews for our scholarships, and we had a project that was proposed to us that was about how to deal with patient property of people that had died. And one of the feedback was that often it was put in a carrier bag and given to the relatives, and sometimes even mixed in with soiled items as well. And this whole project, very similar to yours, was about understanding what that means to the families and the impression that it gives about how their loved one has been cared for in your environment. So if you can't look after the property, how have you looked after my relative? So I think you have absolutely understood the significance of something that some people may think is a small issue, has absolutely got huge impact on experience. So thank you so much. Really insightful. I'm wondering if Becky has got any comments or thoughts on Henry's project.
So impressed, Gemma, by the practical nature, the fundamental things that go unnoticed, but are of pivotal importance, exactly like you say, people's own things when they're removed to somewhere like a hospital where it's all very impersonal and they're using other property. It's so important. And Henry's highlighted such a practical way of managing the process so that it becomes personal. And that's the trick, isn't it? To make a process in place that remains personal and remains individual. And he's made great strides in that. Well done.
Yeah. Thank you. Brilliant. Yeah, I agree, Becky. I think putting Mark at the heart of that project really, it would draw in and engage those that you want to get on board because they see it as significant to the person. So I think that was absolutely so skillfully done. And Maria, any thoughts from you?
Yes, really great. I've made a couple of actions for myself to follow up to see what we do in our organisation. But I think the project really demonstrates a person-centred approach, a person-centred issue, which I think we need to do more and challenge ourselves more. Because when you think of the whole you know, people that are so vulnerable coming into hospital and losing sometimes their rights and their belongings going all as Henry described. And I think it demonstrated, you know, you mentioned blanket restrictions there as well, Henry. And, you know, you put those things together. How do we help you leaders to really create environments that are person-centered and they're least restrictive in terms of practice? So I think this is a really good example, and I definitely will take away from it what we're doing in our organization, because I suspect that we've not considered it at all. So thank you.
Thank you.
Maria. Thank you. So there you go, Henry. Already you have an influence in Lancashire and South Cumbria, which is where Maria's from. So that's fabulous, isn't it? Well done you. Well done you. Okay, let's move on to our next presenter. So next we have Keely Phillips, who's registered mental health nurse. She's going to talk to us about improving confidence in non-nurses in identifying symptoms of physical health conditions prevalent in eating disorders. I'm really fascinated to hear about this one, Keely. So whenever you're ready, over to you.
Yes, so my project was on improving the confidence level in non-nurses identifying symptoms of the physical health conditions prevalent in eating disorders. Next slide, please. So I identified the area for quality improvement. So our service is occupational therapy led. There are 2 occupational therapists and there's 1.5 nurses, so it's me and 1 occasionally. And the team relies on its nurses for the recognition and treatment of the physical health conditions, which means that there can be potential for delays in the treatment of these conditions. So I felt that by increasing the non-nurse team members' knowledge of the symptoms, that would also increase their confidence in identifying them, which would allow for quicker recognition and treatment. I thought this was also especially true because at the minute we're working virtually. So if groups are facilitated by other team members, it means that I might not see a patient for half a day and potential problems might not get picked up. Next slide, please. Thank you. So to check that there was evidence that improvements could be made in this area, I discussed this with individual team members, and I found that they were able to identify which condition might present itself following certain actions. So if a diabetic patient told us that they'd managed to have their meal, but they didn't have their insulin with them, they knew what that would lead to, but they weren't confident in identifying the symptoms of those conditions. So following that discussion, an anonymous survey was created and completed by all the non-nurse team members to establish their baseline confidence levels in identifying these symptoms, the conditions, and these were hypoglycemia, hyperglycemia, hypokalemia, hyponatremia, and anemia. So all confirmed as well that they knew, they'd heard of those conditions and they knew what could lead to those. It was just the confidence in identifying the symptoms. So as you can see from that pie chart there, no one was extremely confident, and the highest range was obviously not so confident, and there was also some that they were not at all confident in identifying. Next slide, please. Thank you. So the PDSA cycles for this were as follows. So I listed the symptoms of those 5 physical health conditions, and at first they felt that it was too long. So we've removed some of those. By cycle 3, they were saying that there was nursing jargon and they didn't understand some of it. So like on hyperglycemia, on hypoglycemia, increased thirst was previously polydipsia, and they said they wouldn't remember that, so we took that out. Whilst it's not there now as well, there was low blood pressure under anemia, and that was originally hypotension, so that was changed. But then by cycle 4, we thought that it wouldn't be helpful for them to have symptoms listed that they wouldn't actually be able to check for themselves, so they didn't feel confident to do the blood pressure. So we thought there's no point in having that in there. So we did things that they felt that they would be able to ascertain. So whether it was through their own observations or through asking the patient, do you feel this? Do you feel that? And then by cycle 5, we had a group discussion on the symptoms and queries were answered. And then the final list is obviously of the cards is what was distributed to the team. Next slide, please. Thank you. So the outcome. So the results of the anonymous surveys, first the baseline survey and then the final survey following PDSA-5 were compared to determine if confidence levels in identifying the symptoms had improved. So the results indicated that team members went from mainly not so confident, which was 36% before the intervention, to very confident, which came out at 80% after PDSA cycle 5. So following the intervention, there were also no longer any symptoms that team members felt not so confident or not at all confident in identifying. Next slide, please. So my key learning from this project, it was important to have clear communication to share the aims and the reasoning behind the project with the team. Reflective listening was imperative as it enabled the team members to feel listened to, and it also helped me to determine which changes needed to be made following each of my PDSA cycles. I learned about the importance of empowerment. So I originally thought that I might include mnemonics on the symptom list cards, but actually the team members felt that they were able to come up with their own ways of remembering the different symptoms, which in turn made them more confident in identifying those. I also considered potential issues and limitations that might have arisen and thought about how I would eradicate these. And my last point was, do not doubt the receptiveness of your team to new ideas. I was a bit unsure about how they would take this because it was so physical health orientated, but they were actually really receptive to this project, and I'm glad I was able to undertake it. Thank you.
Well done, Keely. Fantastic. Congratulations. Thank you. Brilliant job. Now I saw Susanna doing thumbs ups and nods there, so I know Susanna will want to make a comment on that.
Brilliant, Keely. Really, really nice use of PDSAs. I think you created that empowerment. Your approach created people to be able to say, we don't like this, it could be better, or this will work better for us. And quite often we don't make that time in the NHS, and therefore we impose our jargon on people and they don't realise. And that's really, really nice example of how to work with people and not design, actually try things out with them. I think it's really good. Are you happy with the results yourself?
Yeah, I'm really happy with how it came out, and yeah, definitely agree. It was so useful to have the kind of input from the team throughout, because that really helped shape where it was going to go and be successful kind of for all.
It takes real confidence. I think there's a thing about being a leader, being confident to show something and work with people that is not perfect, because then they will tell you how to make it perfect. And there's real confidence in that approach. So well done. Yeah.
Thank you.
Thank you. And any other comments from our audience? Thoughts? Reflections? Give me a wave. I've got Maria and Becky wanting to wave at me. Let's go. Let's go for Maria first.
Thank you, Gemma. Keely, I was just wondering, is the work still going on? Because it's really important work in terms of improving physical health for our service users. Has it continued after you've done the project?
Yes, so we still have a monthly meeting and discussion around the physical health symptoms, just to make sure everyone's still remembering them, still feeling confident in being able to identify them if they meet with a patient.
Fantastic, brilliant. And Becky?
There are two constant battles for us, aren't there? There's the parity of esteem agenda, where we look after people as whole people. And then there's also the services, and the gaps between services are where people fall. People get excellent care and treatment, but when it's somebody's job and not somebody else's, that's when people fall down, and that's where care falls down. Like I said right at the beginning, we are, as a profession, biomedical psychosocial practitioners. That doesn't mean we have to do all of those things, but it means when it comes to leadership, we can often be the people who get that real umbrella view of the needs that people have right across the spectrum. And that's why I'm so impressed, Rachel. It ticks so many boxes for us in terms of the development of the workforce, because it's often in the field of eating disorders where the physical and the mental health are so intertwined that it's often the most difficult nut to crack to get those people who are involved in the care and treatment of this particular client group to understand that it's the awareness and the identification and the working collaborative with colleagues that means you get the best holistic care. I think you're in a perfect place to do that, and you've done a great job. Thank you.
Thanks, Becky. Thank you. I couldn't agree more. I feel like this is the perfect example of PDSA in action, because what you could have done was imposed your solution. And as the expert in this area, you could have imposed your solution on this issue, but you didn't approach it in that way. You suggested a way forward, and you refined it over several cycles of that PDSA until it's actually a tool that is fit for purpose and is addressing the issue that you were hoping to achieve. And that is really admirable, Keely. It's I think a lot of people in very significant leadership positions could learn a lot from your approach. So really well done.
Thank you.
Okay, let's move on to our next presenter. So we're doing well for time. Thanks everybody that's helping me out. Keep to schedule here. You're doing fantastically. Our next presenter is Rachel Holmes, and Rachel's going to be talking to us about her observation of a quality improvement project.
Good morning, everyone. First of all, apologies, I can only join you for the QI segment. Unfortunately, I've got some other commitments today, and I'm also managing an outbreak of COVID on my ward, unfortunately. So I just wanted to take this opportunity to say thank you for the opportunity. I've really enjoyed the course, and it's nice to see everyone's faces, and hopefully we'll be able to meet in person sometime in the near future. Okay, so my name's Rachel. I work in a medium secure mental health forensic unit in London, very busy acute ward. So my QI project is around enhanced observations, and my team's QI project grew from an ongoing project about the frequency and duration of enhanced observations and trying to reduce those. So what we did was we started by using the 5 whys root cause analysis method, and we identified that the quality of our enhanced observations remained a problem. So we sat down as a team to think about what exactly we were trying to accomplish and why it mattered to service users and also staff. Next slide, please. So we identified that there were barriers and challenges to undertaking enhanced observations, which included the ward environment, staff involvement, and staff competence and confidence in undertaking the enhanced observations. Also service user involvement and documentation. So taking all those things into consideration, we came up with a project aim, which is to improve the experience of enhanced observations for adult male inpatients in a secure forensic mental health unit in order to increase satisfaction by 75% within 6 months. So that was our aim. We collected both qualitative and quantitative data using a staff and a service user questionnaire. And we also continued to collect the data on the frequency and the duration of the observations, which was part of the original project. Next slide, please. Thank you. So we adapted a driver diagram which mapped out our primary and secondary drivers and also the change ideas that we'd come up with as a team. The change ideas included, we have sort of an observation badge that we actually ordered off eBay and identified that it needs to be more of a protected hour, and it's a bit like a baton. You hand it over to the next nurse that is doing the OBS. It's able to be cleaned down, so in terms of infection control, it's safe. That has worked really well. Also upskilling staff in competence and encouraging their confidence in meaningful engagement during enhanced observations. So it not being just a tick box exercise related to risk, that actually we need to engage with the patient. So there's something called the Merseycare Supportive Observations Recording Tool, which is part of our observation policy. So we're developing some training regarding that for staff. Then we used the satisfaction questionnaires for staff and service users to collect the baseline data, and also used it to measure if our PDSA cycles have been successful. And then also just simple things like, are we reviewing the OBS daily with the service user involved? So one of the other change ideas was just adding a prompt to something called our safety huddle book, which we do as part of our morning handovers, just to remind us, do they still need to be on OBS? Has the risk reduced? Have we talked to them about it? So that simple change also was helpful. Next slide, please. So in terms of the questionnaire data, and you can just move to the next slide as well, please. We surveyed service users first, collected baseline data. We only got 3 responses, which, as we know, is a bit of a limitation. But in any case, it gave us something to start with and shaped our aim and direction and helped us develop our change ideas. Next slide, please. Thank you. So the outcomes highlighted, we were not actually meaningfully engaging or involving service users in reviews of their observations. So I won't go through all the data, but it was quite clear that we weren't actually engaging with these service users in a meaningful way. Next slide, please. And then the crux of it was 3 people said they were fairly satisfied, which is good, but obviously we want them to be very satisfied. Next slide, please. Thank you. So we also were thinking about staff. So we developed and came up with a staff questionnaire as well, which we got 10 responses for. These are both anonymous questionnaires. The survey of staff helped to identify examples of things that we did as staff, or barriers that stopped us from engaging meaningfully. So you can go to the next slide, thanks. So there was kind of mixed reviews about how confident and competent people were about understanding the role and purpose of the observation nurse. Did they feel as though they were involved in reviews? So this was helpful to capture all that information. Next slide, please. And then we asked for examples about what the barriers were and also examples of things that worked. So we got loads of good suggestions about things that we do well. So our sensory box, offering fresh air, one-to-one support, actually talking to the patients. But then we talked about the barriers, which was, low staffing levels, high acuity, competing tasks. Sometimes when service users are paranoid, that may mean that it might increase their paranoia more if they're on enhanced observations. And also there was quite a theme about the team not feeling included in the reviews, and sometimes it feels as though the doctors are making that decision and not the whole team. So this was helpful, and that helped shape our change ideas in terms of the OBS badge, protected hour, and nurses being involved in the reviews. Next slide, please. Oh, this is just a snapshot of the overall satisfaction of staff, the staff service that we used for comparison. Next slide, please. Okay, so then we resurveyed service users 2 months later. So this was captured in December. Again, we got 3 responses. What we did on this occasion was target the service users that had been on enhanced OBS quite recently. So now we've got an embedded practice where we give the questionnaire to service users when their enhanced OBS are terminated. What the outcomes identified and showed us was that our change ideas had been successful. There's still lots of outstanding work to do in terms of staff education and documentation, and it's still very much an ongoing project. Next slide, please. But these are the survey responses from the 3 that we surveyed 2 months later. As you can see, there's lots more examples about how we'd meaningfully engaged, so social cooking, using the iPad, one-to-one internet groups, and a service user had also indicated that they felt that staff talking to them was very supportive. Next slide, please. And then as you can see, we got 2 totally satisfied and 1 fairly satisfied. So that is an improvement on the previous baseline survey. Next slide, please. So inevitably, as is the same with everyone's project, COVID-19 has impacted the momentum of the project, but we still meet fortnightly via Microsoft Teams. We've got a QI coach who supports us as well. The whole MDT are involved, service users are involved as well. We also talk about the project at our weekly community meetings, with staff at our away days, and also our CIG meetings as well. So the next steps for us are developing a staff training project around meaningful engagement, which is something that's ongoing. And then we're going to resurvey staff again following this to measure if there's been an improvement in their satisfaction of carrying out enhanced OBS. Next slide, please. Okay, so what did I learn as a leader? Well, I guess the project enabled me to develop my leadership skills, increase my confidence. I was able to focus on influencing positive change, which I think was really helpful in terms of involving the whole team from the start. It helped. We identified a common goal, common purpose strategy. We had quite a clear direction, and I think that was quite inspirational. So people didn't feel like they were just being told what to do. They felt part of the project. So I think that really helped. And the whole team was involved in the change ideas. Meeting, as I said, fortnightly and keeping up that momentum also helped, despite the challenges of COVID. And again, involving the service users has been really key as well. I think one of the barriers that I came across was it's quite difficult to change attitudes and sort of systemic workplace attitudes, particularly around enhanced observations about them being, a tick box exercise or it's just another task. But what's really surprised me is like the teamwork and just really involving everyone, like at the grassroots from the start, has really meant that the project has been a success. And yeah, my team has been wonderful. And that's everything. If you want to go to the next slide, it's just my poster presentation.
Brilliant.
It's probably quite small, you might not be able to see it. But yeah, thank you. That's everything.
Fantastic. Well done, Rachel. Brilliant job. I was thinking the same as you were talking, Rachel. This is about culture change, isn't it? Rather than a task that you've changed the function of. This is actually about attitudes and values and reframing something that's a tick box into a therapeutic opportunity and interaction. So even though it might seem on the surface quite a simple thing, actually the depth of it and the layers of it are significant. So well done for tackling something that I think, again, big impact, potentially big impact. Now Becky's nodding at me. Becky, did you want to comment?
Oh, I was before I became a crisis practitioner, I was in patient nurse for a long time. And Rachel, credit to you for tackling what seems to be a simple interventional examination of a task. It is not, exactly like Gemma says and you've articulated. This is about the whole relationship between your staff group and the patients that they serve. And I think one of the things to be borne in mind as you continue this great piece of work is that relationship between all or nothing in the acuity of your environments these days. Every environment's acute now, and everybody's so busy and the staffing levels are like they are. So navigating with your patients, going from all or nothing, the idea of being on constant enhanced observations and that then stopping, and patients then maybe reporting that, well, I don't want to bother you because you look so busy, but I miss the quality time, but I don't want you to have to observe me visit the toilet. There's got to be somewhere in between. And how you navigate a phased approach between being with someone all the time and being with somebody in a quality way some of the time is, I think it's something that's really difficult, and credit to you for tackling the whole issue. The other thing for me as an educator is I've been amazed over the years by the lack of knowledge, skills and abilities that often non-registered staff have in completing this intervention. It's the most important intervention on your ward, and it's often done by the least qualified, officially qualified, but most skilled often of the staff group. And it's about their understanding of why they're doing what they're doing. And within that, those limitations of what they need to do, still having therapeutic and meaningful contact. And I heard that all the way through your presentation, Rachel. Brilliant stuff, brilliant stuff. I'm outstanding by what's been going on today. It's amazing.
Thank you, Becky.
Thank you very much. Thank you.
Any other thoughts, comments? Maria?
Absolutely fantastic project. This is something that's really close to my heart. And I've put in for our objectives at Lancashire this year to do work, and this is a fantastic example. This is kind of what work I want across all our wards, to really make our environments much more therapeutic, to support our staff, to do meaningful interventions with patients, and to turn the whole thing around, which I think this project has just given us. And I love the way that you include service users in the project, and you got the whole team involved. And I think, you know, it warms my heart to hear the projects this morning, because if we could get, you know, a number of people doing projects like this, how different would our services be for service users? How different would they be for places to work? So I really, I love this project, and it's something I have made some phone number details here, and it's something I will be taking forward. And I think we as nurses need to lead this work, and this is in our area. This is on, you know, and just kind of reflecting, I was on a ward recently, and all the registered nurses were in the office, and all the healthcare support workers were in the ward area. And, you know, coming back to what Rebecca said about, you know, the people that are doing the most contact with our patients are our healthcare support workers. I want to enable our registered nurses to be able to do therapeutic interventions on the ward. So we're going to be looking at that next year to make sure that there's always a registered nurse facilitated to be actually on the ward, and not tied up in the office. So this is a really fantastic project, I think, that we should all take on board. Thank you.
Absolutely. Fantastic. Thank you, Maria. And thank you so much, Rachel. That was wonderful. And I understand you've got to nip off now, but thank you for joining us and sharing.
Yeah, I do apologise. I'm sad I can't join you for the whole day, but yeah, just a huge thanks to everyone and all the teachers and facilitators, and you, Gemma, as well. And yeah, nice to see everyone in my cohort. Hope to see you in person soon.
Yeah, absolutely. Thanks, Rachel.
Right, thank you.
And our final presenter is Andy. Now, I know, Andy, you have opted not to use PowerPoint, so it's going to be a narrative, we'll call it, shall we, presentation.
That's right, yeah, I apologise, I didn't have the capacity to complete a PowerPoint.
Don't worry, it's fine. It's definitely not compulsory. Whenever you're ready.
So my project was about improving morale and boosting performance on a psychiatric intensive care unit. So I took over as a ward manager on a PQ in September last year. And the first thing that struck me was the staff morale was dire. There was groups forming on the ward. Staff weren't talking to certain staff, and it seemed that only a particular group of staff were responding to emergencies. And I was concerned about the dynamics on the team and what support could be offered to help improve that, really. So the aim was basically to see what we could do as senior managers to help the morale on the PQ, support the staff, and take it forward from there. So what we did was we created a survey for all the staff to complete, and that was sent off start of October. And out of 25 staff, only 11 members of staff completed it and sent it back. And some of the comments there were there's no teamwork on the ward, the support's really poor, there's no support from management, the ward seems depleted and very low morale, they don't enjoy coming to work. Some of them, there was quite positive feedback as well, such as some of the colleagues feel that they were friendly and polite and supportive. But the most striking things were that there was no support on the ward. So following this, we then looked at supervision, because we found that they felt the staff thought the supervision wasn't necessary. They didn't feel anything came from it. So we looked at the supervision structure on the ward, and it appeared from reviewing previous supervision notes, a lot of staff were saying no issues, there's nothing wrong. So we delved deeper into that, and we changed how we did with supervision to make it more focused on them. And then it came to light that they didn't feel confident in managing crisis on the ward, managing incidents, and especially violence and aggression. And in particular, quite a few staff highlighted they weren't pleased with managing patients in seclusion. So we explored that, and then I did some research on the incident reports, and I found out that a lot of staff were getting injured when they were entering and leaving seclusion. So I contacted our physical intervention team and asked for specific training for entering and leaving seclusion. Now they assured me that this was done, which I know it was, but I asked if they could do it in our seclusion room if it was free. So we pushed all the members of staff through the physical intervention training in a space of 3 months. So everyone was up to date. They all had the up-to-date knowledge about how to manage patients in seclusion. And their confidence grew massively following this. And that was clear because the staff injury rates have gone down significantly. So some of that we keep pushing, and we've then asked other wards to do the same, and now they're doing that as well, which is really good. We looked at the staff meetings as well, and staff weren't attending the meetings, which we were quite concerned about. So again, we changed how they were structured and made them more, focused about the staff, and ensured that the senior manager, so myself, a clinical nurse specialist, service managers and general managers attended these meetings. And since they attended, the staff just completely offloaded, and it made them feel more comfortable that they were getting listened to. So now the senior managers step back, and it's just chaired by myself, and more staff are attending, which is really positive. And we had a meeting this week, and it was really good to see how many staff attended. So what we've done on Friday was we sent another survey out to all the staff, and so far we've already had 6 responses. So compared to the last survey that went out, that was available for a month, in a space of a few days, we've already had half of what we had previously. And I've just seen emails now saying that more staff responded, which is really good. And I've seen some responses there which have said that they feel extremely supported on the ward. There's more presence from senior managers, and they feel like, so they've commented on, like, they feel like myself and the clinical nurse specialists are involved in incidents a lot more. So we deliberately took a step forward to lead from the front in them situations, just to try and empower the staff. So that seems to have had a positive input. We've also allocated staff now to certain roles on the ward, so taking lead of infection control, taking lead in seclusion audits and so forth. And that's purely to empower them. And again, they've owned that, they've taken that, and they've smashed it. Done such a really good job. For me, what I've learned massively was, reasoning with the staff, listening, and empowerment was massive. So that's the biggest thing that we did. We empowered the staff, I feel. And because of that, now they've skyrocketed and they're flourishing. And that's been noted by senior members of the trust, general managers, members of the board. And it's something that I'm hoping to pass on to other ward managers where I work, to try and support them in managing their staff morale, because at the minute, because of COVID and extremely high acuity across different wards, it is quite low morale. But PQ itself has been mentioned about being quite a good place at the minute to work, which I was really proud of. But yeah, that's it. Thank you very much.
Thank you, Andy. Well done. Brilliant. Fantastic work. I feel like you described in a few minutes there probably about 15 different QI projects and multiple cycles, just that all offshoot from that issue of low morale. And my instant reaction was a theme that ran through it for me was about the safety for the staff. And obviously it was safety on a physical sense because they were getting injured, but also through your clinical supervision, you were offering them a psychologically safe space as well. And without that, those fundamentals of safety being addressed, we would never address any issues around morale or willingness or positivity towards workplace. So I feel like you got right to the core of the issues. So that was really excellent to hear. Thank you, Andy. And must be so rewarding for you to see that transformation in this period of time. So
absolutely, it's been really positive. The feedback that we've had from senior managers has been really good, and I think that this course helped us, because when I first started this course, I wasn't in this role, so I do believe that what I've learned from here I've definitely used in practice.
Brilliant, thank you. And thoughts, comments from others? Maria, do you have any comments, reflections?
Yeah, I think Andy, it really kind of demonstrates really, I guess, your kind of creativity as well in trying to resolve the problem in terms of you know, staff feeling safe and confident, and how you approach that by really using systems that we have in place that sometimes I think can become a tick box, like supervision, and making supervision really supportive and developmental. And I like the outcome in terms of building the confidence in staff, because if we have really confident teams, then you know, it's going to change everything from the staff satisfaction to the outcomes for patients. So again, I would commend how you approach that, and again, some learning around, you know, we sometimes sheep dip people, don't we, into mandatory training. Oh, everybody goes do their positive and safe. But actually, by you bringing that training into your ward and supporting the staff do it on the ward, it sounds like that's made one of the big difference for people to build their confidence. So well done.
Thank you very much.
Yeah,
Thank you, Maria.
the thing that really struck me, Andy, was that you were really genuinely listening to what people's concerns were. I think, and seeing what the issues were, and by addressing them. One of the things I would always say, low survey response rate in itself is a measure. It means people not attending meetings is a measure of engagement and their value and the worth, and getting the response both quantitatively and qualitatively. You're demonstrating the impact of that. In one way, it's quite superficial towards the actual impact in terms of safety and how staff are feeling, and the impact that will go on to patients. So yeah, really, really, really well done. And again, yet another fantastic presentation.
Really excellent. Thank you,
very much.
Susanna. And Becky?
Oh my. It's amazing on this programme, Andy, you don't mind tackling the tough issues, and I think it's those fundamental acceptances of who we are as a profession, and the idea that it's your job to turn up and look competent and capable. I think until somebody comes along and tells you you can retire, well, you're just going to stand there and look it, and the difficulty is to admit that you're not. I bet has been for some participants of this programme part of the journey, about having a space and a time and a place in which you can say, I don't know, I don't understand, it's not right, I can't process this. It's the only way to get through some of it, to start learning, and to create an environment where that can happen. I think for you as a ward manager is fundamental, Andy. And it's a great way you've displayed here about starting that process. We're doing a huge project in HE about trauma sensitivity, and the way I've been trying to explain it to colleagues is it's not about an educational programme so the staff can be more trauma informed. It's about taking staff to a place where they can admit that sometimes in their desperate need to provide care, that can be quite traumatic, and traumatic for everyone. So this is a really important project in terms of that journey about staff understanding their feelings, their impact on other people, reflecting on why they do what they do, and in order to be able to do it better, just like this programme. Well done, Andy, well done.
Thank you very much.
Thank you, Becky.
Can I just say, as a sorry, can I just say, from obviously I've been in Andy's cohort since the beginning as well, a bit like sort of Anastasia's project, and seeing it from the beginning where you weren't a ward manager, weren't you? I mean, we were discussing about how we can implement this on the ward, and I suppose having seen you go through this change to become in this sort of position where you can implement it and you've seen actual change has been like really nice, I suppose, from an observer point of view. Like I said, just to see where you've come from. So, I mean, this is a project that could be applied to any team in any mental health area, geographical area, anything like that. So, bring it over to Nottingham and we'll put it in our team.
Absolutely.
Yeah, it's lovely to see. So well done.
Cheers.
Absolutely. We talk constantly about patient safety, don't we? But I don't know how often I hear people talk about staff safety and thinking about it in the lines that you have, Andy. That's just fantastic. Well done, and thank you for sharing. And thank you to all of our presenters. I think that they've just really highlighted the influence that those small ideas, those germs and pearls that you bring from your positions, your unique positions within your organisations and your unique insight as mental health nurses, and how you use all of those skills in negotiating, relationship building, engaging with others to generate the types of changes that we know need to happen. And it really, I always say that relationships are our superpower, as mental health nurses, and every single one of you has utilised that superpower to make this change happen. And Maria, there are 50 mental health nurses on this programme, so that's 50 change products. I would love to have hundreds of them. I really, really would. So thank you so much, everybody, and well done. We're going to move on now to our guest speaker, who you've met already, but I want to introduce you to Maria Neilligan, who's Executive Director of Nursing and Quality at Lancashire and South Cumbria Trust. Now, a bit similar to Becky, I could give you a list of all of her achievements and her really impressive CV, but you guys can Google her and find that out. I want to tell you a bit about my interaction with Maria and the reason why I wanted her to meet you guys. I've been meeting with lots of chief nurses recently because we opened up and launched the Florence Nightingale Foundation as a member organisation. So probably 3 or 4 chief nurses a week I'll have a conversation with about the potential benefits. And Maria and I met a few weeks ago, and I felt like I had met somebody who was part of my tribe. It was just an instant connection. And I think the reason for that was because we don't see many mental health nurses in the position that Maria is in. We don't see that kind of representation. And I felt hugely proud of what she achieved and the influence that she was having. And we had a whole conversation about her perception of nurses as professionals and the barriers that they encounter and the potential opportunity and influence that they can have when we start to consider ourselves as professionals on an equal footing to all of the other multidisciplinary team. And those messages sat with me. I reflected on them and I thought, well, they can't just sit with me. I want her to share those messages with others on the programme. So we've invited Maria on to give you some thoughts and reflections as you embark on your next phase following the programme.
Thank you, Gemma. And thank you everybody for giving me the time today. I kind of decided to talk about myself, which is something that I don't normally do, and only because in the context of you guys starting out your career in quality improvement and leadership, and kind of just share some of my thoughts with you and kind of how I got to where I am, because I believe it's something like 1% of nurses become chief nurses, so it's a small number. And also maybe just to blow something else out of the water, I'm not a mental health nurse. I'm actually a learning disability. I'm actually a learning disability nurse, and there's 2 of us in the country that are chief nurses. But I have spent I suppose the last 20 years in terms of nurse leadership in mental health, learning disabilities, and CAMHS. And what I guess I'm passionate about nursing, whichever specialty it is. I think nursing is a fantastic profession, and I hope that my little journey will lead us to help with some of our reflections and discussion maybe later. So it's a very much a personal reflection. So I just would like to share that with you today, if you're happy for me to go ahead. Is that okay, Gemma?
Yeah, absolutely spot on.
Okay, so I've started off. That's myself and my graduation in I'll say 1984, and I didn't start out to be a registered nurse. I wanted to be an artist and do fine art. And when I was 16, I started doing some voluntary work with people with learning disabilities. And a light bulb went on for me, and I thought, I need to do, I need to be a nurse. I need to be supporting people, working with people. So I stayed back a year in school and took on biology, because obviously you can hear from my accent, I'm Irish. And in Ireland at that time, you had to have a science subject, English and maths, to get into nursing. And it was a fairly prestigious profession to go into in Ireland. There were more applicants than there were places, and a lot of Irish people went to England to do their nursing and came back. So it was probably a very exciting time. Next slide, please. And at that time, I guess I wasn't thinking about leadership. And there wasn't opportunities like you have now, like getting involved in QI, going to university and doing your masters, a whole host of opportunities. And really, my first step into being a registrant was very much about establishing myself as a practitioner. A big part of that was learning from others. You know, I can think back and remember, you know, the first registered nurse that taught me how to do my first depot injection. The first nurse, I can remember my public health, we had public health nurses in Ireland, which would be the equivalent to district nurses, taking me out and getting me to do all kinds of physical interventions that I would never have dreamt of. You know, meeting, and that meeting people in their own homes, meeting people in their families and in different situations. And that kind of put a little seed in my head about, oh, I think I might like to be a community nurse in the future. So the first years were very much developing my communication skills with families, GPs and external to the organisation. A key bit in learning disabilities and very similar mental health is advocacy, and advocating for people that are, you know, in a minority group, that are, you know, in a Cinderella services. I think, you know, we've acknowledged mental health is in a Cinderella service. Well, you can imagine that learning disabilities is even more of a Cinderella service. Rebecca mentioned parity of STEAM. You know, back in the 80s, that wasn't a concept that was there at all. But I have to say, and I will reflect when we move forward, some of the things that I've seen in the 80s are still evident now here in learning disabilities and mental health in terms of parity and aspirations. Developing skills, as you could imagine, your key skills around assessment and intervention, and collaboration and working and team building. So another passion of mine would be very much about the multidisciplinary team and how we as nurses are key to that multidisciplinary team and how we perform as leaders within the multidisciplinary team. And kind of reflecting back as well, when I kind of said I wanted to be a nurse, my father said, well, that's a very hard job for a woman. And I still remember saying that, because I was thinking, well, Dad, you know, who else does it? All respect to the male nurses here, but at that time it was in Ireland very traditional female dominated profession. Next slide, please. And then I had the most fantastic opportunity to go to Australia, and this is me here with the hat. And that was my 24th birthday. And at that time in Australia, they were moving to university education for nurses. So moving away from hospital-based education, which I'd been part of. So as a result, they'd had an international recruitment to get registered nurses over to Australia to work on the wards because all their student nurses were going into university. Can you go back one, please? And so we were in Australia, and that really opened my eyes up into really different ways of practicing. And Australia was very much at that time, education was very much available for registered nurses. There was an expectation that people would go on and do their degrees. It was supported by the hospitals. It was supported by the universities. I can remember I started doing a diploma in nursing at night, and the support that was there to do it in terms of not only time from work, but remuneration in terms of salary, tax benefits, whatever. They really were trying to move the profession up a notch in terms of both practice and academic ability. So next slide, please. So of course, when I started off my student nurse years, I met the gorgeous Paul, and Paul was a student nurse a year behind me. And I can't say we fell in love at first sight, or but we certainly felt we were certainly in love now, should I say. And we he begged me to come back to Ireland, well, England. He'd moved to England, and he had completed his registered nurse, but decided nursing wasn't for him. He couldn't do with the rules. He couldn't do with, you know, the procedures. So he decided that he would become a teacher. So he begged me to come back to England for a year, so he could finish his degree, and then we could go back to Australia. So that was in 1990, and I'm still waiting to go back, and it's a big joke in our house. So I had the fantastic opportunity of becoming a community nurse on the Wirral in Merseyside. And they were really happy years because I developed really a lot of confidence. And I would say probably listening to the projects that we've heard today, I started doing some of those projects. Obviously, I didn't have the, I guess, the support that you guys have had in terms of quality improvement. Quality improvement methodology wasn't there at the time. So it was doing things like looking at policy, looking at practice, also looking at audit, and using audit to improve practice. And I then went through a number of roles, and I guess anything that came up, I kind of had to go at. You know, so I you know, went from staff nurse, community nurse, team coordinator, and I'm going to talk a little bit in a minute about education, but at the same time, I had started getting a thirst for knowledge, really, because I wanted to be a better nurse. How could I be better? How could I really have that knowledge that I could put into practice? And also, how could I influence other nurses to do the same? How, you know, how could I go about that? And then an opportunity came up in terms of you'll all be aware of CCGs, but the precursors to there were PCTs, and they came up with this idea of having a board nurse, or a nurse that would actually be a clinician that would be on the board. And I happened to say to our director of nursing at the time, I'm really interested in doing that. And he said to me, leave it alone, Maria, leave that to a proper nurse, obviously meaning an adult nurse. So I wasn't happy with that, as you can imagine. And I kind of thought, no, I'm going ahead with that. And I was up against the health visitors, the district nurses, and myself, and there was two roles, myself and a district nurse got the role. And that started probably a 7-year experience working as a board nurse and leading, you know, a group of nurses, and also leading on mental health for that PCT. And that taught me, actually, you know, run with your heart and run with your mind, and don't let anybody pigeonhole you into something. And having to say, that was the director of nursing that said that to me at the time was a mental health nurse and a learning disability nurse. So that says a lot, really, I guess, in terms about where he saw himself as well. And so, and all of this time, I wasn't thinking about, I want to be a chief nurse. I was just wanted to be the best I could be, work in my team and see what I could do to improve my team and the services that we provided. And then I got to the point where I was clinical service manager, and that gave me scope, really, for a whole host of experiences with the voluntary sector, experiences with stakeholders of all kinds of descriptions, and also looking at patient complaints. And you know, that's why I suppose that Henry's project, I don't know how many complaints I've seen over the years about patient property being lost and about families being traumatized by it. So at that point, I got to kind of really learn and really work with families, and that was the approach I would take, is very much go and meet the family. You know, not hide behind the letters, not hide behind the formalities of it. We are, as nurses, we are communicators, and communicate with the family, and you know, together demonstrate the compassion that we have as human beings for each other and for our difficulties, and put that back together. And then the opportunity of a deputy director of nursing came up, and I thought, well, I've nothing to lose, I'll apply for that. Next slide, please. And I got it, what moved into that post. And running, of course, alongside those roles were this drive I had for knowledge, because I felt I needed to know more. I needed to have the knowledge to underpin my leadership, to underpin my practice. So I started off, I did a DPSN for you guys, that's a Diploma in Professional Studies in Nursing. And then I took some time out of work to do my BA Honours in Health Studies, Diploma in Community Nursing, Certificate in Teaching. And then I started the Masters because I thought, well, actually, a consultant nurses were just coming out, and a consultant nurse I thought was the best job that you could have, because you had a mixture of professional development, education, research, but clinical practice as well. So you could still support patients directly, their families. And I thought that was the pinnacle. That was the job I wanted to do. So I started on my research. I did practitioner research by research. And I loved that course. But of course, there was no consultant nurses posts near where I lived. So I had to, and I couldn't move. So I had to apply for the deputy director post, because what I wanted to be able to do as well was to influence nursing practice, to influence the profession, to help improve standards. Next slide, please. During this time, I became a mum as well to my lovely Orla. And she's just my pleasure, but she's also third-year student nurse. She's gone to the other side, so she's doing adult nursing. But we call it the family business now in our house, is the joke, because there's 3 of us in the house and nurses, and all very proud. And but during this time, I was doing my master's, and I became deputy director of nursing. And that gave me a fantastic platform really to learn all kinds of things. And I kind of look at it, I learned everything about emergency planning, for example. You know, who would thought that I would know anything about emergency planning? And I had to become the trust expert in emergency planning. Clinical policies, took a lead in that, close to my heart. Education and CPD. So I took the lead on the CPD development, working with HR around the workforce plan, working with Health Education England. It would have been the precursor to that. Infection control, I became the director of infection control, the DIPSI, in my role as deputy. I introduced an e-rostering service and the temporary staffing service. So that was, you know, so I set up, so I got both operational, professional and clinical expertise during those years. All that time with having a passion really around the practice development. Next slide, please. And I think at this time, I hadn't planned on moving. I thought I'll see my career out. There's so much here for me. And I was very much working on the education and workforce development area. And then I got tapped on the shoulder about would I be interested in becoming a director of nursing. I can remember speaking to colleagues and they say, oh yeah, you should have done it years ago. Go and see this chief executive. And so I did. And I had the most fantastic conversation with somebody that was really person-centered and really about driving quality and really driving the quality of services that we deliver in the NHS. And I thought, I've got to go. I've got, you know, at this point, Orla was 16 and I decided she could get herself to school at this point, and I applied for the post. And these are just some pictures really of, I think in the middle you might recognize Tommy Whitelaw, the campaigner around dementia. And Tommy used to come, I had an annual Nurses Day, and we would have a big celebration. We would share projects like you guys have done today, best practice. We developed a nursing strategy, launched the nursing strategy. And the picture on the left, that's myself with my deputy. And that was taken on the day that we became an outstanding trust. And the other picture is my leaving day. So if we go to the next slide, please. And I can't tell you this role, the joy I've had in this role, and the personal and professional satisfaction. And one of the things that I focused on was around person-centered care and quality improvement. And you know, I think sometimes we say person-centered care. I mean that across all elements of the service. So I established a service user care council, where the service users council were part of, the chair was part of our board. They were part of all our committees, that where we did any quality improvement, service improvement and developments, that there was always a service user at the table, and they were become a part and parcel of how we did things around here. So that engagement was a big piece of the work. And obviously developing the professional leadership within the trust. There had been very little done around supporting nurses and HPs in their academic development. When I got there, nobody had a master's that was in any clinical area. So I went about changing that, and I introduced some consultant nurses into CAMHS, adult mental health, learning disabilities. So started doing that, and also sending people on advanced practice programs, along with doing professional leadership programs for our ward managers and our deputy ward managers, so that we started really getting in that confidence and leadership. And a big focus on care planning and risk assessment, and person-centered care planning risk assessment. And I guess the outcome of that was from 2015 to 2019, we went from a requires improvement trust to an outstanding trust. And, you know, that was absolutely a fantastic experience to lead and to be part of. And next slide, please. And that's the cake, of course, that we had on the day we got the result. And I got to cut it, which was fantastic. Next slide, please. Oh, and that's me getting my COVID jab. We're going to talk about that in the next slide, please. So where am I now? So, you know, each role that I've done, each program I've done is built, I think, on my experience, my leadership skills, and my values, to take me where I'm at now. So I left the fantastic, outstanding trust to come to an RI trust, which is Lancashire and South Cumbria, and we're one of the most challenged mental health and community trusts in the country. I've been here 18 months, but 12 months of that has been during COVID, and I have been just blown away, I have to say, about how our nurses have responded to the challenge of the pandemic and to the challenge of COVID, how people have pulled together, how they've demonstrated true resilience in terms of working for our patients and our service users. And we're doing that alongside having to make improvements across a whole number of areas, having to develop new services as a result of the investment that we are now getting in mental health, which kind of comes back to Rebecca's point about parity esteem. We're on that journey. We're not there yet, but we do have quite a bit to do. And you know, I was kind of reflecting, saying, well, what have I done since I've been here? And obviously, as DIPSI, we've had to respond to the COVID pandemic and make sure that staff and service users are safe. We've also developed a mental health resilience hub. So that's around supporting people that are traumatized as a result of COVID, and particularly working with our acute trust colleagues around, you know, critical care nurses, and supporting them. And we've also developed a workplace trauma support program, where our psychology team go out and work with teams and help them work on their resilience from a psychological perspective, and that we're rolling that right across the organisation. And what I've spent the past 20 years really across mental health leadership, mental health and learning disabilities, I have been given the opportunity from our chief exec to be able to lead our transformation of our learning disability services, and have come to be the system leader for learning disabilities. And that's been a fantastic personal opportunity, because it means I've been able to go back to my roots a bit. I've been able to look at supporting our learning disability nurses and really looking at things like health facilitation, which will be similar to the health facilitation in mental health around physical checks for our service users. And the whole, you know, bringing that physical and mental health together. How do we bring the whole person together in a really, really person-centered way? And I've brought with me some of the things that I've done in my previous trust, like a Service User Care Council has been established. But I guess the biggest thing, and that I want to take a couple of minutes to say, is implementing the new clinical and professional structure. So I'm lucky that my chief executive sees things similar to what I do. But also, I guess I need to be an influencer, and I think that's the key part of our role as nurses, as being influencers as well. So we've now set about implementing a new structure that is locality based, but enhanced professional leadership. So we've now put in a triumvirate. So we have a director of nursing, a director of ops, and a medical director in each of those localities. So that for me is 5 new directors of nursing that will have a focus on nursing and quality. And underneath them, there is a number of associate directors of nursing who are consultant nurses that also will take a role around professional leadership and support. And if you look at the box on the left, when this is all implemented, we'll have 20 consultant nurses, 18 consultant AHPs, 60 nursing associates, 60 peer support workers. I feel passionately about supporting our service users and people with lived experience into employment. We in our trust are a big employer, so we need to make sure that we support people with lived experience into employment. 18 advanced practitioners and 6 non-medical ACs. So I guess that's what I'm going to be working on, I guess, in the coming months. That is something I'm really proud of. We know that we have challenges in getting registrants, and I'm glad to hear the numbers are up. But I want people to work in our trust and value being a nurse, proud to be a nurse, but also see that they have a career working in our organisation, which is from healthcare support worker right through to consultant and now director of nursing as well. And I think if we come to the next slide, please. And I think if I was kind of reflecting back and thinking of you guys and the energy and the fantastic positive impact that you're having on your profession, but also for patient care. And I was kind of thinking, if I was looking back, what would I kind of say to myself, going back to, if you go back that time when I was in Australia, or go back to when I was a student nurse. And I think I would say to myself and advise myself, patients first and center is always right. Take every opportunity that comes your way. And this course is obviously one of them. Be proud to be a nurse. It is a privilege. Learning is a continual process. And I'm really keen to support learning for everybody. So, our healthcare support workers as well. Embrace diversity in life. Speak out for what's right. And when I think of that, I kind of go back to being a student nurse. And I was a bit of a, I wasn't afraid of speaking up. And remember, in those days, you'd have to ask your tutor for a reference so that you could take it for your next job. And I asked my tutor, the one that was giving me the certificate there actually, asked her for a reference. And in the middle of the reference, it was, there was something in it said that Maria is very outspoken. And when I read that reference in 1984, I took that to be a negative. I took that being outspoken was something that was negative and was something that I needed to change. And I never shared that reference with anybody. And I kept it. But of course, over the years, I have learned that speaking out is not a negative attribution, it's a positive one. And I would encourage everybody to speak out, whoever they are and wherever they are. But I still have kept that letter, and I keep meaning to put it in a frame so that I can remind myself and everybody else as well. And believe in yourself. I think believing in yourself, putting yourself forward, I think is what we all need to embrace. And you guys have put yourself forward for your course today. You've presented to one another. Every time you do that, it gets easier and easier. It builds your confidence. and it helps you develop your leadership for the next part of your career journey. Next slide, please. Thank you.
Thank you. Brilliant. Amazing, Maria. Thank you so much. Such huge insights there into what has been such a significant career with amazing achievements, tangible impacts that we heard there on the quality of services that's not only felt by those that are using it and those that work within it, but looked at by external people and judged as outstanding, and taking all of that learning into your new environment to start that journey again. Maria, I think just shows that commitment and resilience. So fantastic, what amazing messages. And there was one thing I thought that stood out to me when you said about yourself as an influencer. Nurses are influencers, and we hammer that message home on these programs because we don't necessarily encompass that into the nursing identity, and it's something that we want to challenge. So thank you, that really reiterated that for us. Okay, so our next part, you've listened a lot this morning, and thank you for doing that, and hopefully it's raised lots of thoughts and reflections for you, and we want to give you opportunity now to be able to talk through those things and connect with each other. So we're going to go out into some breakout rooms for about 20 minutes, and it's entirely up to you how you want to use that time together. There will be people from both of the cohorts, so hopefully you'll meet some people you haven't had a chance to connect with yet. What we would like you to come back with is a word that describes what this programme has meant to you. So an individual word from each one of you that represents your experience and the meaning that you attribute to this opportunity. And what we will do, we've been recording the session for those that couldn't make it today, but we'll edit that bit out and you can keep that as a memory of today when we come back into the full group. So if that's okay with everyone, we'll see you again. You'll be automatically teleported out. You don't need to do anything, and we'll see you in 20 minutes time to hear your reflections. Well, welcome back everyone. I think we've got everyone back now from your breakout rooms. I hope you've had some opportunity to talk and reflect and share your experiences. If we were doing this in a live event, we would be handing out your certificates and your badges now, and we will absolutely have opportunity to do that at some point. We'll post out when we're back in the office from whenever we're able to. We'll post out those certificates and badges to you, but we will also plan an event for you as alumni to come together in the new times when we can have big groups together and we can celebrate and share a buffet and all of those crazy things that we've not been able to do for all these months. So please be reassured that at some point we'll get a chance to do that cheers and share a glass of champagne together. But for now, what we want to do is to capture this celebration for you at this point in the programme. So what I'm going to ask Miriam to do is to call out all of your names. And as she calls out your name, if you take yourself off mute and tell us that one word that you've identified that represents the programme to you. Now, Miriam is always behind the scenes doing a fabulous job. She's one of the key people that makes this programme such an amazing experience, as are other people in the FNF team. But Miriam is our programme manager. So this is her time, I think, as well, to have an opportunity to be part of your celebration, and wish you well. So whenever you're ready, Miriam.
Thank you, Gemma. Hello, everyone. It is lovely to meet you all. And I'm just so excited. And I love the QI projects or the presentations that were read out this morning. They was just so good. And so I'm going to read out the names. I'm going to start off with cohort 1. And when I read out your name, you can just say something about the program, what you got out of the program, or anything that you loved about the program. And so the first person is Katie Jackson.
We're just saying the word, aren't we? Is that right?
Yes.
Thanks. Empowering. It's been really empowering.
Thank you, Katie. Prince Isabel. Katie Seller. Rhiannon Tana.
Hello, everybody. My chosen word was inspiring, but it incorporated lots of other words. It's just been very inspiring to see sort of everybody's projects and all the opportunities that have been made available as a result of it. And it's just been a great experience learning from all of you. I think I've learned more from our breakout rooms and sort of engaging with you all sort of in a closer way as I have from sort of the PowerPoints and things, but it's been really good sharing knowledge with everybody, and Radha was fantastic.
Thank you, Rhiannon. Martin Upong. Henry Akaluka.
I'd say since the program, I mean, this program has provided me with loads of opportunities, and one other thing is made me realize a lot is that myself, I've grown in confidence, and I've acquired quite a few skills. So my chosen word, opportunities.
Thank you, Henry. Keely Phillips.
Sorry, it's this laptop. My word would be eye-opening. It's been really nice to learn about everyone's different professions and the guest speakers it's also been really great to see what kind of things you could go on to. So yeah, eye-opening for me.
Thank you, Keely. Israel Ankilande.
Hello, good afternoon. I'm sorry to interrupt. It's Princess Ibo. I know you already called my name. Unfortunately, I was having connection problem at that time. Now I am back and still struggling with the video bit of it. But in any case, I will be able to respond now if you would give me another opportunity. Thank you.
No. Yes, definitely. You can respond now.
You go for it, Prince.
Okay. Yeah. Good afternoon, everybody, and I welcome you back again. I'm really happy to see all the faces. Yes, about this program. I started this program with pomp and pageantry, and I got all the support I needed to go through it. Unfortunately, at the point of submission, at the point of submitting my project, now here I have tears dropping down yeah, I went through a very protracted experience with the COVID illness, and I'm just recovering. I'm still recuperating, and unfortunately, that brought about my loss of contact with my team and other quality control teams that were really supporting me in getting the project through. So as of now, I've taken that project as a work in progress, and that hasn't really affected the knowledge and the experience and skills I gained from participating in the program. So for all those who were able to submit their projects, I wish you and my hearty congratulations to you all, and hope at some point we'll come across each other again. So yeah, I'm still struggling to regain my strength after my COVID illness, and I do not really want to say so much. I thank you all and congratulations for completing the project. Thank you.
Thank you so much, Prince, and I hope you're feeling better now. Ali Dorba.
So I've loved this course. It's been amazing. My word is a bit contradictory. I found the course really light. I've always felt really happy about turning up, and it's been an absolute breath of fresh air in comparison to what's going on perhaps in my working life at the moment, with it being a global pandemic. But the word that I want to use is strength. I think that it has given me strength in lots of different ways. Yeah, so that's me. Thank you.
Thank you, Ali. And now we're moving on to cohort 2, and we're starting off with Charlotte Goodall.
Hi everyone, good afternoon. For me, I'd say proud. Proud to have had the opportunity. I've met all of you and learned from you. Proud to have had the opportunity to do the course and learn all these new skills and experiences, and it's kind of given me a fresh look at being a nurse and made me feel really proud to be a nurse and the opportunities we have and the work we're doing at the moment. So proud for me.
Thank you, Charlotte. Samantha Manicum-Bird.
Hi, my word that I've chosen is metamorphosis, because I think it just encapsulates a lot of the changes that I think we've all gone through during this this course. There's been so many, almost everybody I speak to has been gone to a different position or a different place of work, or there's lots of changes being made because of the COVID. So I think we've all gone through a change for that. But also it's made me realise just how much nursing changes as well, and how my skills and everything help me to develop into something much better and bigger than I already am. I think it's a continual change, and I feel very, very positive and good about that. So yeah, metamorphosis is my word. Thank you for listening to me ramble.
Thank you, Samantha. Michael Grisdeck.
Hi everyone. So my word is encouraging. I think it's been encouraging to see people within my cohort develop, seeing them come along the journey. It's really nice that they've all taken on board the learning opportunities, and also encouraging to see how people develop, how we can develop others within our teams at work by using and implementing these new skills that we've had, that we've learned, and also encouraging that we are able to actually influence change and carry that forward. So yeah, my word is encouraging. Thank you.
Thank you. And next we've got Anastasia Freya.
Hi everyone, my word is broadening. So I feel that being on the program's really kind of broadened my horizons, my knowledge, my understanding of I guess what, you know, us as nurses a bit more in an ongoing changing climate, and it's been lovely to get to know everyone in my cohort and see how everyone's developed and changed.
Thank you. Emily Green. We've got Sarapia Mutami.
My word is enabling. This course has been quite good. It enabled me to unleash a leader inside of me, and to be able to make an impact on our ward. And I think the impact the training has had on me is not just on my ward. It's something that I'm going to take further, you know, trust-wide, if not countrywide or worldwide. There is no limit.
Thank you. Lauren Proctor.
So my word is transformational, actually. So I think it just shows how having a little bit of sort of passion or enthusiasm for something to change can make sort of real change in your workplace. And just thank you to everybody that has as well listened to me and discussed things with me and reflected with me, and it's been an amazing opportunity, and I made some sort of really real friends, even though it's been on sort of a virtual world. So thank you to everyone.
Thank you. Jess Kinghorn.
My word is remarkable. I think just this course, each and every one of you are amazing and are remarkable nurses, and it's been a pleasure to obviously get to know you all, but just the power that this course, you can be having a bit of a down week, you come on this course and I feel so inspired every single time. So I just want to say thank you for that. It's been a great experience.
Kelly Davison.
Hello. My word, I suppose, is a bit passionate, because I think I'd lost my way a little bit. I think when we started this course, my ward particularly was quite low morale. the staff team had changed massively, and I think it just gave me the passion that I felt for to be a nurse, why I wanted to be a nurse, and it's kind of reignited that. And we're like one big family, you know, like Lauren was saying, we've made friends for life, and you know, even on those dark days, we still had the WhatsApp group where we could just kind of check in, and especially for me, I've been off shielding since January this time, so it's been nice to actually have the, you know, the guys at the end of the phone just to like check in and say hi. So yeah, passionate and supportive.
Rachel Thompson.
My word would be powerful. It's been, like some of the others have said, really nice to get back on the meetings and see how everyone's doing and how the course has had an impact in kind of things that have happened in their clinical practice, and being able to see kind of immediate changes that people have been able to make that have made such a difference to them and to their patients has been amazing. And some of the speakers we've had have had really powerful messages as well, so it's been really nice to be able to listen to them.
Andy Hudson.
My word would be development, because I think I've developed as a nurse and as a leader, but also personally as well. I thoroughly enjoyed the course. I think it's been fantastic. Thank you very much.
Thank you, Andy. And lastly, we've got Spiwe Mombe.
My word is progression, because I think every day when we were having these programs, there was something we were coming up and learn from each and every topic. And as we were from different environments and different areas, I think we share the ideas and we learn from each other.
Thank you. Thank you, Spiwe. Was there anyone that I missed out?
I haven't said my word yet.
Oh, sorry about that, Becky. Please go ahead.
I'd say confidence. I think I've taken something from every session that's helped build my confidence in dealing with a lot of things at work and personally. So.
Thank you. So I'm so sorry, I lost connection midway through there. I don't know if you noticed me disappear. I had a panic, but I'm back now, and I'm sorry that I missed some of those words, because that kind of feedback to us at the foundation is really so important. We need to hear the difference, to share that with others that commission our services as well. So thank you for that. I'm glad that it's recorded. I will absolutely watch that back. So the final part of our morning is really to talk to you about next steps. And I've already mentioned this, and Greta mentioned as well, that you are now officially part of our alumni community, and the networking opportunities that offers to you. So our alumni are extensive, significant, influential, but also very generous. And that's the key with our alumni community. There's around 1,500 nurses across the UK that are part of that community, that all have valued the input from FNF and are motivated to give back. So what that means is when we put a shout out for a little bit of help for someone, that we get offers, and people are very keen to be able to offer what they've learned and to open up the opportunities that have been opened for them. So first things first is that community is now available to you, and I would really urge you to make the most of it. And the other part is around the opportunities that some of you have already taken up. So we get requests from policymakers to undertake different pieces of work on their behalf, or to nominate people to sit on various different panels, advisory groups. And this is your mechanism now to take what you've learned in your local areas and the impact that you've made onto a national platform if you want to pursue those kinds of opportunities. So my message is that when the newsletters come out to you, opening up these opportunities, not to think, oh, that one was talking to Ali or Michael, it didn't apply to me. It does. It applies to every single one of you. We're inviting you, and we want to have your contribution, and we would really encourage you to take us up on those offers. So I know a lot of you are already influencing on the postgraduate education that the Tavistock are leading on, and I've had lots of great feedback from the insights that your group have brought. So that's an opportunity that's come about already. And I want to introduce you to Adam in my team. Adam is our alumni manager. So he is your main point of contact now. Adam, would you like to say?
Yes, certainly. Well, welcome everyone. Congratulations all on your mental health nurse leadership program. It was really, it's only my second one I've attended, and not coming from a nursing background, it was really wonderful to hear some of the stories and the all the different commitments. I'm choked up already. And Gemma probably missed out because she cut off, but some of the words that came out that really inspired me were, empowering, encouraging, passionate, proud, and that's what I am as well, feeling with all you guys just come through the program. But as the alumni and membership manager, as Gemma mentioned, it has opened up the community to you, and she mentioned the advisory groups, but we also have case studies that we're looking at to hear your stories, what you've gone through, not just maybe on the program, but how you got to this as well. So it'd be interesting to hear from those that wish to contribute to that. And as part of the newsletters, it also opens up the opportunities to join our workshops and webinars that we provide. So it'd be good if you could partake in those. So have a look at those. And also, being part of Wellbeing, you can contribute to the Lesiva books, which are looking for people to contribute to Wellbeing particularly, so that might be useful. But yes, I hope to speak to some of you in the near future and to help us build our story on our website.
Thank you, Adam. And I can see that Greta's popped back up, and I'm sure Greta will want to offer you some final thoughts and reflections.
Thank you so much. I popped back up, my picture popped back up, but I was listening most of all of that time. So really, thank you. I indulged myself in the story and the way of working of mental health nurses, and I really enjoyed it. Thank you. Wow, I have to say, wow, what an amazing group. What passion, what commitments that you've demonstrated, not just in those improvement projects of those that presented, but across the whole cohort, the support of each other, those amazing words that you've described of each other, that you've described of the programme, the support you've got from each other. I missed the name of the nurse at the end who was holding a rather lovely pink cushion, but the fact that she exemplified the fact that this group has been a support to each other, and I thought that was just amazing. I loved listening to Maria, and if Becky's still on the call, Becky from HE is still on the call. I love that. I did have the chance of talking to Maria offline when you were all in your breakout groups. But I guess my message that I took home from Maria, if I was listening as a clearly much younger nurse, would be take every single opportunity that you're offered. Somebody has picked you out as being super. You do not get offered opportunities if you're not any good. So take it for granted that you are brilliant. And if somebody's seen you and they want you to do something, take that as an opportunity. It might not be part of your career pathway. And I was reflecting to Maria that actually, I don't know whether that's peculiar to nurses who trained in the hospital-based system, like myself and Maria, but neither of us, we both declared to each other that neither of us have had a career pathway. We took opportunities, we enjoyed it, and kind of with the opportunities is following your heart. So if it feels good, just do it. You don't know where it's going to go. Certainly if you get to a block, a T-junction, then that's fine. You can look for the next opportunity. But whatever opportunity you do, just think it's going to add to your CV, and it will encourage you to be even better. So reach for the stars is my message. Now, Becky mentioned Westminster Abbey, and it brings me to mention Westminster Abbey again, because I can't remember on the proposal, but you might have seen that we advertised Westminster Abbey as a special event for people on our leadership programs at the end. Well, of course, that is the opportunity, but it's not again this year, unfortunately. Last year we had to cancel it when it was Florence Nightingale's bicentenary. This year we've cancelled it again, but we have conceded of having a very small group of people at Westminster Abbey. So the invite will go out to you for next year. We won't forget you. It's just I don't want you to see something in the press or in our newsletters about Westminster Abbey and think, well, actually, where was my invite? The invite has just been pushed back to next year. And I'm really sorry, we're probably only going to have 50 people, but I'm sure you understand. And some of those things that you guys said when you were reflecting back just then was what network you've got. You've got WhatsApp groups. You are a network of mental health nurses, albeit in different cohorts, but use each other. You know, you've got a group of people that think the same as you do, talk the same as you do, aspire to do the same things as each other. So make sure you use each other. It's an informal network, and those are often the best. Adam mentioned about the facilities, the alumni facilities, but I urge you to join our communities on our portal, and Adam will send you details about that. I'm a member of a community, 2 communities actually outside of nursing, and the amount of support you get from it, people post questions, you can respond, you can send documents. Has anybody got a document for this? Would you mind sharing it? Absolutely fabulous. And so there's no point in reinventing stuff if somebody else has got that. So use each other. And the most important thing is never forget that you've been on this leadership program. We will know who you are. And I know Becky said, how do you tell a mental health nurse? I'm sure there's a joke there, but I won't possess to think about a joke. But how do you tell a mental health nurse in Westminster Abbey? I don't know, but we will know who you are, definitely. And the door is always open for you. You are part of our family now, big family, 1,500 people in our alumni network. And if you ever need us, just email one of us, any of us. If you're stuck in your career and you just need a bit of a help, then please be in touch. We know so many people that can support you. So just remember that the door is always open. So lovely to meet you all. One day I'll see you in person, but go forth and multiply. Your responsibility now is to find the next person on the next program. And if HE is still listening, that's not a plug for can we have some more funding for another program? But if there is, that would be nice. Thank you so much. Well done, everybody. Bye bye.
Thank you. Thank you. Bye bye, everyone.